Right, so in this discussion, we'll look at the lungs. The previous one, we were looking at the neurovascular bundle. We also looked at the rib cage. Now, we'll look at the actual lungs. So, lungs, these are the two largest organs found within the thoracic cage. So, we have the left and the right lung. Needless to say, these are cone-shaped organs. So the lungs are cone-shaped. They have a wide base and a narrow apex there. So that is a base, or what you can call the diaphragmatic surface. And this is the apex of the lung. So the apex of the lung is always slightly, that is about 2 centimeters projecting into the neck. So if you palpate yourself just above the collarbone there, next to the neck, you are actually touching on the apex of the lung. Therefore, a patient with a stab wound in that region, about 2 centimeters above the clavicle, would have damage to the apex of the lung. It is easy to identify the lungs because they are the largest organs there. Now, how can we differentiate the left from the right? So first of all, we see that both lungs have what we call the oblique fissure. So this is the oblique fissure here, and this is oblique fissure. So whether it is left or right lung, they both have an oblique fissure as demonstrated here. So the oblique fissure separates the superior lobe from the inferior lobe. Superior lobe, inferior lobe. But on the right lung, there's another fissure here, cutting across. So we call that as horizontal or transverse fissure. Therefore, dividing the superior lobe into a superior one and an inferior one. So therefore, the right lung is going to have 3 lobes: superior lobe, middle lobe, and inferior lobe, whereas the left lung only has 2, which is superior lobe and inferior lobe. Needless to say, in the inner surface there, on the left lung, just next to the heart, there's a small lobe called lingula. If you check in this diagram here, this part here, this is where the lung, the heart will be. This is known as lingular lobe. So equally it has 3 lobes, but it is too small to be considered as a major lobe. So that is lingular lobe of the lung. Okay, apart from that, the left lung has this depression here. So this depression is created by the left ventricle of the heart. So we call this as a cardiac notch. It is a notch created by the heart, hence the name cardiac notch. Okay. So those are the features of still sweeping. All right, I'll wait a bit then. So that is a cardiac notch. Yeah, sorry for that. Okay, then in the medial surface of the lung, you see that there's a hilum. So this is a hilum here, and that is a hilum. Now, in the hilum, we see that there are 3 structures there. There's a bronchus entering the lung, then there's the pulmonary arteries entering the lung, and the pulmonary vein exiting the lung. So the pulmonary arteries are carrying deoxygenated blood. Remember, these are the only arteries in the body that carry deoxygenated blood. Then the pulmonary vein is carrying oxygenated blood. Now, I want you to get me correctly here. To say, in the right lung, we see that at the hilum, in the right lung, at the hilum, there is first of all a bronchus entering there. You can see that the bronchus is superior. Then we can also see that there are two pulmonary arteries. This one, these are the two pulmonary arteries entering the lung. Then we have one pulmonary vein leaving the lung. So on the right lung, the bronchus is the superiormost structure in the hilum. It is the one located at the apex here. But when it comes to the left lung, you see that it is a vein that is located in the superiormost aspect there. So that is a vein, bronchus, and the two pulmonary arteries. So we use this, apart from identifying the fissures on the surface of the lung. You see that on the right lung, there are two fissures. We can also use the hilum to identify which one is left lung, which one is right lung, because on the left lung, the pulmonary vein lies in the superiormost aspect within the hilum, as compared to the right lung, where it is the right bronchus that lies in the superiormost aspect. So I want you to remember those facts because may come in your exam. Okay. Next, we look at segments. Now, each lung, apart from having lobes, you see that the left one has 2 lobes, the right one has 3 lobes. The lung is further divided into bronchial segments. So these were the bronchial lobes. Now we're looking at bronchial segments. Now, each segment is said to be shaped like a pyramid. So a pyramid is more like a triangle, okay, except that the apex of the pyramid is not as sharp as a triangle. So what you are seeing here in colors are segments. Now, in total, whether it is the left lung or the right lung, in all human beings, it's either you have 8 segments, both in the left and right lung, or you have 10 segments, left and right lung. So some individuals have 8 segments, whereas others have 10 segments. So there's that variation. Nevertheless, that doesn't affect the normal function of the lungs. It is just a variation that is considered as a normal thing in human beings, because human beings, we are never perfect and we are never exactly the same. Even though we may have identical twins, they will not have similar structures in their body. There will be some variations here and there. So segments can only be 8 or 10. That being said, I want to draw you back to the bronchus now. So we said this is a trachea, this is a carina, located at T thoracic vertebrae number 5. Then from there, it divides into right and left primary bronchus, or many bronchus, if you like. So these are the many bronchus, many bronchus. Now, of the two, it is the right primary bronchus that is more vertical. Aside from that, it is said to be wider in terms of diameter than the left bronchus. So there are 2 features in the right bronchus that are missing in the left one. So this is more vertical and wider, whereas the left one is said to be slightly horizontal or oblique, if you like, and smaller because there's a heart here. So the heart is in the mid, just behind the sternum there, but it is more leaned. It is more leaned to the left, and therefore causes this tube to be a bit horizontal to allow room for the heart here. Because of that, if there's any aspiration of foreign bodies, most likely that foreign body will find itself in the right lung rather than the left lung, because of those 2 features we have mentioned. This is common in pediatric cases where a baby may swallow a cork stopper, a toy, or anything, and that object goes all the way and lodges into the right many bronchus. So the moment the bronchus enters into the lung, it splits into 3 on the right and 2 on the left. So we now call them as secondary bronchus. We call them as secondary bronchus. Secondary bronchus. So on the right lung, since there are 3 lobes, you're going to have 3 secondary bronchus. 1, 2, 3. This is going to the superior lobe, middle lobe, inferior lobe. This is going to superior lobe and inferior lobe on the left side. So left side 2. Now, since we said there are about 8 or 10 segments, depending on your genetic makeup, you may have 10 segments in each lung, or you may have 10, or you may have 8. So 8 or 10. So depending on the number of segments that your lung has, is going to determine the number of tertiary bronchus that we have. Now, tertiary bronchus supply segments. So each segment will receive a branch from the secondary bronchus. Okay. Then within each segment, the bronchus now begins to divide and form bronchioles. So bronchioles are now arising from the tertiary bronchus. So you see these divisions. Those are now going to the segments. So we call them tertiary bronchus. Now, there is no major difference apart from size between the trachea, the main bronchus or the primary bronchus, the secondary bronchus, and the tertiary bronchus, because all of them, yes, are muscular tubes. Aside from that, all of them have hyaline cartilage, like we discussed. So there is hyaline cartilage, and this cartilage enables the respiratory tract to remain open, or what we say patent, so that air can easily flow from the upper airway to the lower airway, like we established to say there is upper respiratory tract and lower respiratory tract. Okay. So that is it about primary, secondary, and tertiary bronchus. Now, when we go to bronchioles, bronchioles lack the hyaline cartilage. So this will not be present in bronchioles. So that's how you can know. You can differentiate bronchioles from bronchus just by the absence or presence of cartilage. If there's cartilage, you're still looking at smaller bronchus, which can be tertiary, supplying the segments. Now, once that is not present, so what remains now is just smooth muscle. So this disappears in bronchioles. And because of that, now we are going to have 2 types of bronchioles. The first ones to branch off from the tertiary bronchus are the terminal bronchioles. Okay, now, terminal bronchioles are part of the conduction portion. Then from there, they keep on dividing and getting smaller. Finally give us respiratory bronchioles. It is the respiratory bronchioles that are part of the respiratory portion where gaseous exchange takes place. Then from there, we have alveolar ducts connecting to alveolar sacs. Even those 2 structures are involved in gaseous exchange. So now, okay, this is mentioned already, roots of the lung. Okay, now in the trachea, we're saying there are certain procedures that can be performed. For example, is tracheostomy. So tracheostomy is simply an incision made into the trachea. It is a vertical incision, by the way, made into the trachea to create an artificial opening. Okay, now, I'll take you to the structure of the trachea, which we saw much earlier on. So what happens here is this. This is a inferior part of the larynx. We call this as a cricoid cartilage. Cricoid cartilage immediately below is the trachea. So this is the first ring of the trachea. So there are about 15 or 20 rings of cartilage in the trachea. So this is ring number 1, 2, 3. So it is safe to perform tracheostomy at ring number 3 going down, and then you insert a tube there. Cutting through the trachea here at ring number 1, number 2 is considered not to be highly safe because that is closer to the vocal cords. And when the trachea is cut into, so during that healing process, when the scar tissue forms, that can interfere with speech production there. So that's why it is recommended that the incision is made at ring number 3 going down. Skin is first make an incision, vertical incision in the skin at that level, separate the skin, then cut through the trachea and insert the tube. That is done if there is obstruction to the larynx, or what you say, the upper respiratory tract, because we said it is within the larynx at the level of the vocal cords where there is division between upper and lower respiratory tract. Okay. So it can be a temporal tracheostomy or indeed a permanent one in this case. Okay. So a tube is inserted, the balloon is inflated, then air will be passing through this tube to reach the lower respiratory tract. Okay. Then here we're seeing endotracheal tube intubation being done on the patient, trying to visualize the lower respiratory tract. Okay. So that is it about the lungs. Okay. Next is the pleural membranes. Now, we're saying in the thoracic cavity there, we have pleural membranes. Now, we discussed the thoracic wall. We also discussed the lungs. Okay, now, within the thoracic cavity, there are pleural membranes. And this was slightly discussed in introduction. Now, pleural membranes are a protective covering around the lungs. So there are 2 layers of pleural membranes. We have what we call the parietal pleural membrane, or the outer pleural membrane. We also have what we call the inner pleural membrane, or rather the visceral pleural membrane. Now, it is the visceral pleural membrane that is in close contact with the lungs. So when you remove the lungs from the body, you see that they will have an outer shiny surface. That is a visceral pleural. Now, the visceral pleural is always attached to the lung and you can't separate it. Okay, so it becomes part and parcel of the lung. Then the one that is now covering the wall of the chest inside there will be the parietal pleural. And therefore, there is always a small, minute space between the parietal and the pleural, the parietal and the visceral pleural. We call that as a pleural cavity. Now, that cavity is important because it is filled with a serous fluid. This is fluid that is watery in nature, and it is the cells of the visceral pleural that produce this fluid. Now, this fluid is maintained under a constant and normal ranges. For example, that's just for example, if 20 mils is produced in 24 hours, then 20 mils is reabsorbed in that 24 hours. So you find that at any given time, at any given minute, the amount of fluid in the pleural cavity is constant. Now, for some instance, for example, if there's disease to do with the lower respiratory tract, disease with the lungs, tuberculosis, pneumonia, and the rest, this can cause an inflammatory process whereby fluid now shifts from the blood vessels within the pleural membrane, that is a visceral pleural, and accumulate within the pleural cavity, a condition known as pleural effusion. Sometimes trauma may occur to the chest wall. This can be blunt or penetrating trauma. Still, there will be inflammatory process. If it is penetrating trauma, blood will now collect within the pleural cavity, and you call that as hemothorax. And if there's still opening there, air can also find its way there. Then it can be a combination of air and blood, hemopneumothorax, or just blood itself called hemothorax. Now, we're saying within the chest cavity is the heart. Okay, so as we can see here, the lungs have been reflected so that we can see this space here. So this space where the heart was, it has been removed here. We call it the mediastinum. Mediastinum. So mediastinum is a space between the lungs, and that is where the heart is found. So it is divided into superior and inferior mediastinum, exactly at the sternal angle of Louis. That is at level of rib number 2. You said that is the sternal angle of Louis or sternocmanubrio joint. If you cut a horizontal line there, going up is superior mediastinum. Let me go back to that diagram here. Okay. There. If you draw a horizontal line cutting through this level, the sternal angle of Louis or sternocmanubrio joint, above up to this level, the superior part of the manubrium is superior mediastinum. From here going down all the way to the diaphragm, we call that as inferior mediastinum. This is the line I was showing here. Okay, so this line here is cutting through there. Then this line is cutting at T9. That's where the diaphragm is. Okay, so at the sternal angle of Louis, going up is superior mediastinum, which is here. Going down is inferior mediastinum. That's where the heart is located. Now, the inferior mediastinum is further divided into anterior, middle, and posterior. So the space in front of the heart there is called anterior inferior mediastinum, because the whole lot here is inferior mediastinum. Now it will be called anterior mediastinum. Then the space where the heart is, we call it the middle inferior mediastinum. Then the space behind the heart, where the aorta is passing, so it's a space between the heart and the vertebral bone here. We call it the posterior inferior mediastinum. Those 3 parts. So question may come. The heart is located in the middle inferior mediastinum. So when someone says inferior mediastinum, well, they are correct, but they're not as accurate as someone who mentioned to say it is the middle portion of the inferior mediastinum. That's where the heart is located. Okay. So this is all for today concerning the lungs. Okay. So here we're looking at relations of the lungs, but really at this level, I don't go much into that. So, but since you have the notes, you can go through on your own, but rarely ask you a question about such. Okay. So this is, again, showing us the medial surface of the lungs. Now from Netter's, this is an atlas of anatomy. I was emphasizing to say on the right lung, you see that it is the bronchus that is superior, but on the left lung, it is the pulmonary vein that is superior. And we use this as identifying features. You can know which one is the left lung, which one is the right lung. Now, when lungs are removed from a living subject, especially adult, okay, like you and I, who have lived for some years on life, you find that it will not be as red as it is appearing here. It will be darkish, okay, because of various fumes that we inhale on a daily basis. Okay, toxic gases, smoke from burning, waste matter, They are not as red as that. So the more red they are, those lungs belong to a young person. They are still healthy. Whereas it is lungs from someone who has been smoking for a longer period of time throughout their life, you find that their lungs are completely dark. So we see these when we're doing postmortems and when we are doing dissections as we learn human anatomy. Okay. And if chance allows, we can have that time to go and see these things in the laboratory. Otherwise, this is where we end today for the lungs. The other things is on the immediate surface of the lungs, we find that it has several markings. We see these depressions, swellings, and the likes. These are structures. Okay, for example, this is a descending aorta or the thoracic aorta that creates this impression. On the right side, this will be the esophagus making that impression, and that is aorta also. So in front here is trachea, then there is esophagus. Okay, then there is subclavian artery, but really that is just for yourself if you want to know more about the lungs. So this is where I'll end for today. Okay, again, if there are any questions concerning topics that we have already covered, or maybe even this one, just feel free to let me know. You can inbox me directly or give me a call anytime. I'll be able to respond to that. Okay. So we see you in the next session.